Hello and welcome to our first Gastro Learning Live of 2022. I'm George Webster, and it gives me huge pleasure to welcome a real expert on the topic of inflammatory bowel disease and endoscopy related to it. Dr. Mark Salmon from Guy's and St Thomas's Hospital. And we will be discussing with him as the expert and me as the interested party over the next 30 minutes. Not the clever stuff, not the latest on biological agents in inflammatory bowel disease, but actually the sort of questions that we as clinicians face regularly. Which is, how do we get started in the assessment of patients with inflammatory bowel disease? Once the diagnosis has been made, what investigations are needed at that stage, how we survey, how we look for dysplasia. And so let's start off, Mark. I mean, it's great to have you with us. Let's start with a basic clinical scenario. And that is the 28-year-old man who has been seen by his GP. He's got chronic diarrhea with some blood. He's had a fecal calprotectin of 1500, and he has been referred, I think not unreasonably, for a colonoscopy. And this is what one is seeing in the rectum. And so, you know, common clinical scenario, and I suppose, simple question, what do we do next? During this endoscopy, do we carry valiantly on to do a full colonoscopy? And what are the situations in which you wouldn't proceed much beyond what we're seeing here?
Okay, well, first of all, thanks, George, to you and Dave for inviting me to have this conversation with you today. I think in this scenario, you go into the rectum and you see some inflammation. You know, you're kind of expecting to see this. So hopefully one will have taken a reasonably focused history to try and get a sense of where the patient is in terms of their symptoms. And I don't mean to be super thorough in your history. I just mean to go into a little bit of their stool frequency, maybe day and night, how much urgency, how much blood, how frequent the blood is. And then, so because you know you're going to see some degree of colitis more than likely in this with that story. And then we see some rectal inflammation. And to answer your question sort of directly, yeah, I mean, with that degree of inflammation we've seen there, which was some mucosal bleeding, bit of erythema, couldn't see any ulceration or erosions, yes, one would carry on. And really what you're then thinking about is, okay, what's the diagnosis? Sounds pretty simple, but, you know, really in this scenario, let's simplify it even further and say, is this going to be a diagnosis of UC or Crohn's disease, or can't I quite tell on this scope? And sometimes you can't. Having said which, this is the best chance to tell, right? This index endoscopy probably is our best chance to really understand whether this is ulcerative colitis or Crohn's disease. After that, once treatments start getting thrown around, it all becomes a little bit more messy. So that's important. The second thing is, okay, how active is the disease that I'm seeing? And, you know, we're going to come on to talk about the scoring systems used. And that they really are our best way of grading the inflammatory process we see and conveying it to the next person who sees this patient in the clinic. So using a score, I think, is really important, and that's where with endoscopists kind of need to upskill ourselves or maintain our skills to make sure we know the scores, we know how they're used, we're using them, you know, frequently enough, or thinking about using them frequently enough that when we need to go to them, they're there. Yeah, go on.
Can I we just saw a nice picture of different levels of severity. And maybe we can show that again as we discuss. When when we do that initial colonoscope insertion, which of these would make you say, do you know what, I've seen enough, I'm not going to push to do a completion colonoscopy in this instance?
It's a really good question. I think the first thing to say is, it does depend on the situation of the patient. If they have symptoms in keeping with acute severe colitis at the time that you happen to be scoping them, you don't want to do a full colonoscopy on them, because the risk of toxic megacolon or toxic dilatation is kind of what everyone worries about. I think we probably egg that in our mind. If this is an outpatient, he's someone who doesn't have symptoms consistent with acute severe colitis, even if he has a Mayo 3 colitis, like you see at the more severe end there. Of course, these are the patients who go into trials, and in trials, of course, some of the entry criterion include a full colonoscopy, and indeed there are scores, endoscopic colitis scores, that involve a full colonoscopy. There's a colitis score that does exactly that. So I don't want to overburden people with concern that they're going to cause harm if someone's got ulcers. I think if someone's got acute severe colitis, they come down to your list for assessment of UC. Yeah, don't do a full colonoscopy on them and try and use minimal insufflation. I think if someone is not in that situation, but you're seeing Mayo 3, and we'll come on to what the Mayo score is, or severe colitis based on the Mayo score, you don't necessarily have to pull out at that moment for risk of causing complications. It is important, as we're going to say after Severity, to know a little bit about the disease extent, because that helps guide your treatment in terms of whether topical therapies are going to be of use. So I think it needs to be slightly weighed up in the balance of where the patient's clinical symptoms. And so that's why I really do implore people to take a very focused, quick history at the time either that you're consenting them, or having popped the scope in. And so long as they're not so sedated that they can't talk to you, you can still ask them a couple of very direct questions about, how long have you got when you need to go to the toilet? You have to rush.
Okay. You are, you will get a lot of referrals of these patients. Just tell us what you like to see and what you don't like to see on the endoscopy report that come to you, because these patients, around the UK, and I'm sure elsewhere, there's now a very organized system of inflammatory bowel disease clinics and multidisciplinary meetings. But many of these patients will not have started their journey from within the IBD service. So what makes you put your head in your hands in terms of an endoscopy report, and what makes you think, oh, this person, they know a thing or two about providing the information that we need?
It's so important, isn't it? Because the last thing you want to have to do is put a patient through another scope to confirm something that's already known, but just not communicated adequately. And I think the best way for us to share a language between centres is using a score. It's easier for UC, and I think it's, to be on the whole, it's much better done for UC. And I think the problem is smaller for UC than it is for Crohn's, and we'll come and talk about that in a moment, I hope. But I think if you can use a score, it tells the person who you're then passing on to that you kind of know, you're aware of the score, what's involved in each stratification of the score, and the score in itself gives you some information that you can use for considering the need for treatment, escalation, de-escalation, whatever. So I think if we can just upskill ourselves to get to that level, that we're able to use a score for UC and ideally for Crohn's, I think we'll be covering some ground.
So we're gonna come on to the scores in just a minute. I want to take us back to the patient in the room, or you've made a diagnosis of presumed ulcerative colitis, let us say. People sometimes worry what they do next with that patient. Yes, they've taken the biopsies, and we'll talk in a second about the histology. They're going to refer them to the IBD clinic. But what else do they do? Is there other imaging they do? What treatments? Let us say the patient has let's say has a mild pancolitis based on your colonoscopy. Now, do we just send them off to the IBD clinic and hope they get seen within the next few weeks and leave them with their symptoms in the interim? What would your advice be? Because the patient wants to get sorted, and it's all very well at the end of that consultation or that endoscopy saying you've got ulcerative colitis. We've referred you on to the experts, but they're not going to thank you perhaps for having another 3 weeks of bloody diarrhea.
No, totally. It's a really pertinent point for patients, because you've got to remember they've waited a long time with symptoms before they get a referral, then they've waited for a referral to get to the clinic, then they've waited for a clinic appointment to get to the endoscopy room. So this is the time to start treatment, as far as I'm concerned. What you study for a mild or moderate pancolitis, even it's a more severe pancolitis, I think generally the right thing to do would be to start mesalazine, and depending on whether it's pancolitis or perhaps a left-sided or just rectal disease, will guide you slightly as to what you can offer them. There's good evidence showing that sort of top and tail therapy is more effective than either alone. It's probably a more involved thing to give a patient a rectal therapy straight from endoscopy, of course. So you just need to explain to them a little bit more about what to use it, because people are okay with taking tablets, less okay with taking rectal therapies. But I would say start with some mesalazine in this patient in whom you've made an endoscopic diagnosis of colitis. Yes, the histology will come through and will be assessed when they come back to the clinic, but really the time to start treatment is now. And I think letting them go home and hope for the clinic to be around in, like you said, 3 weeks, 4 weeks, it's unnecessary. It's an unnecessary delay. I think if someone's got rip-roaring colitis and you're really worried about their symptoms as well as the endoscopic appearances, it's not the wrong thing to start them on some steroids. It's a more contentious issue. I do appreciate that, and it's more contentious still when you get to Crohn's disease. But actually, at the same time, one could think it's slightly contentious or maybe inappropriate to do nothing in that context, right?
Okay, and what about biopsies? The description we've said, a mild pan-ulcerative colitis. Do you want to see 8 pots of 20 biopsies pots, or are you happy with 2 biopsies from the rectum, or what's the point in between?
I think there is a very happy medium in between those two, whereby you get a strip, and it's slightly economic on economic grounds, because you kind of pay per pot, as it were. At least we do. So I tend to get 1 strip, 8 biopsies on it, and I take 2 TI, 2 right, 2 left, and 2 rectum. And I think that will allow you, as well as your endoscopic margins and extent, it will allow us to make a histological assessment of the disease extent, and without using a different pot for every region, which you certainly don't need to do. The pathologist just needs to know which is the proximal end, and that's usually quite standard, isn't it, in most endoscopy services, by the way the nurses align the biopsies on the strip.
Great. Now, you mentioned about scoring systems and the balance with any scoring system, particularly for the non-specialist, is between having a scoring system that is incredibly accurate and finely defines every aspect of the disease, and on the other hand, one that has 40 parameters that people neither have the time nor the memory to apply. Where are we with scoring systems? Is Mayo good enough, or is that being supplanted by others? What's your position?
I think it's kind of a yes to both of those, George. I think the Mayo, to my mind, is good enough. Okay, so I think it imparts the absolutely essential information. It was developed. My understanding, kind of back of an envelope type kind of score derivation a long while ago, and it takes you through from no disease, mild, moderate, and severe, really based on the presence or absence of ulceration, friability, bleeding, and I think this is one we should, if you're doing endoscopy, I think you should have this score in your head, mainly because it really isn't that taxing. And I think we tend to understand that patients with Mayo 2, erosions, or Mayo 3 ulceration, kind of need escalation or a change in their treatment, and that's kind of all you need to know. If you don't practice IBD medicine regularly, that's fine. If you see those kind of features, then I think the right thing to do is refer to the IBD clinic, or send an email to the IBD interested person in your department. I'd be happy to get that if someone said, I've just scoped this patient, they've got Mayo 3 colitis.
Okay.
over to you.
Well, I mean, if the Mayo score is so brilliant, why do you guys in IBD go off and spend lovely weeks together coming up with new scoring systems?
Right. And so
what are they?
Right, and what I said was it's kind of good enough, but I think we can do better than this. And Simon Travis and his colleagues in Oxford put together a score. This is now talking back in 2011, 2012. That was kind of derived in using modern methods for score derivation and validated in a prospective way, and actually has more stratifications. So rather than running 0 to 3, the UC-EIS, which we're just about to see, runs 0 to 8. And so you can imagine more stratification gives you more granularity of detail in terms of understanding response to treatment. For example, how, is this patient getting significantly better with treatment? And it actually has good predictive value. This score, if you're scoring 6, 7, and 8, then the chances of colectomy are much higher, of course, as you'd imagine, than lower scores. And so this, without wanting to sound too simplistic, is a better score in a lot of ways. It's divided up vascular pattern, bleeding, erosions, and ulcers, and you give a score for each of those. And again, it really isn't that complicated, and you don't have to remember every single score. Just have them on a poster in the endoscopy room. That's what I do, truth be told. I like to look at this every time I do a UC scope and say, okay, all right, yeah, right. And there's no shame in that. It's a bit like the BNF. You look in you'd rather look up a drug dose than get it wrong. So I think this is totally fine to have up in your endoscopy rooms. We have them up in ours. And I did go around and put them in every room in UCH as well, I think, when I was working there.
Yeah. Brilliant. And we'll come on to Crohn scoring systems, because I think they're obviously a little bit different. But just these are down the endoscope scoring systems. And again, to the patient, they couldn't care less, whether there's friability or ulcers or whatever. Yeah. What they care about is how they're feeling and whether they're going once a day or 10 times a day with bloody stools. To what extent, just very briefly, to what extent does the endoscopic score correlate with clinical progress and correlate with how you define treatment?
Right. So historically, symptomatic resolution was enough, but it didn't change the natural history of the disease. We didn't improve patient outcomes if you look at them in a really long-term sense. So the field has moved on to wanting to achieve symptomatic resolution. Yes, still very important, always will be, with concurrent endoscopic resolution of inflammation, or at least improvement, a low disease activity state. And we hope, and this remains to be seen, that reaching that goal or achieving that goal will change the natural history of the disease, reduce colectomy in UC and other surgical outcomes, say in Crohn's. In UC, endoscopic disease and symptoms correlate really quite well. In Crohn's, they really can be very, very much disconnected. So I think it's important to look.
Okay, so on that point, tell us a little bit about a couple of quick words about Crohn's disease, because I think we all recognise the likely increased complexity in terms of defining disease activity.
I too appreciate that this is slightly more difficult, and I think there is a greater degree of upskilling kind of that needs to be done, but nonetheless I think it's entirely achievable. This is the simple endoscopic score for Crohn's. There's a more complicated one called the CDEIS, Crohn's Disease Endoscopic Index of Severity, which is much too complicated to use in clinical practice. Okay, but this one divides the colon up into 5 segments, and you score each of these variables in each of the segments, and then you add the score together. So although that sounds like it would take a little bit of time, we're talking literally at the end of doing a colonoscopy, it will take you a minute or two, maybe, sitting in front of this table, which again I have on the wall in my endoscopy rooms, and just do the math. It's really not that hard. And even if you don't give a score or aren't interested in doing a score, I think you should still use the variables in this to describe what you're seeing in each of the segments. And the things you probably are going to describe anyway. Ulcers are important. How much of the surface is affected is important. And of course, a stricture or a stenosis is really important. So you're going to report them anyway. Just put some structure around it, maybe put a number alongside it, and then we're all talking a language that hopefully is common, means something in terms of outcomes, and guides treatment.
I think that's great. I think that's great advice. And I think the point you make is that, if the expert IBD endoscopist is keeping these things on a wall chart, then the rest of us should. Right. And then we end up having a record that is much more, provides much more transferable information for other teams. Can we move on to dysplasia? Because this is the thing that clinicians and patients worry about, and endoscopists worry about in terms of how you detect it, how you survey. So we just want to talk a bit about detection of dysplasia, and then a bit about surveillance.
Yeah.
How should we be detecting dysplasia?
I guess the first, to take it right back to the start, it's really important to allot adequate time. I think if you're doing a dye spray colonoscopy, which is kind of, or has been, the gold standard for dysplasia detection in colonic IBD.
Can I just stop you there?
Go on.
You said that with great authority.
Yeah.
The debate about dye spray, NBI, etc., is that story settled?
No, so I think it's almost recently flipped back, hasn't it? So it has been the gold standard dye spray endoscopy. Now there's data and recommendations indeed suggesting that you can use narrowband, and we are just switching over kind of in real time. We're switching over from doing dye spray to using narrowband imaging or for colonic IBD surveillance. And actually, I'm very happy with that. I actually think the dye spray you concentrated so much on the dye spray that sometimes you didn't spend enough time actually doing the looking. And I think actually now that we've got data supportive of using narrowband imaging, I'm quite looking forward to using that and doing away with the dye spraying. Is my personal feeling. But you need I still think you need time. So I was going to say you need 3 points to do these procedures properly. With dye spray, you definitely did, because you kind of ended up doing 2 colonoscopies almost. I still think we should be booking these as 3-point procedures, even though we're not going to be dye spraying potentially in the future, because this is all about time and washing and having a very good close look, taking away areas that you think might be a little bit iffy. And honestly, it's so subtle. I think when you start doing dye spray endoscopy for colonic IBD, you end up taking a lot of areas away that you think looks a little bit funny, and your histology comes back as relatively normal or post-inflammatory polyp. But I still think you need to spend that time. and look really carefully. And that's clear. And the prep needs to be good.
Okay. And as part of surveillance for dysplasia, the days of non-targeted biopsies are long gone, or?
Yeah, again, that's one of those things that's come and gone. In my practice, and I think most people's practice, and I think what BSG recommend is that you do a high quality endoscopy, ideally with narrowband or dye spray with a high definition scope, and you take targeted biopsies. I don't take non-targeted biopsies for dysplasia surveillance. I do take biopsies because I want to know what histological disease activity there is. And that helps me in a number of ways. Not that histological disease activity is necessarily the target, but I'm interested to know whether there's any histological activity. It sometimes helps you guide treatment decisions, but I don't take them for dysplasia surveillance. I think those days are, in my practice anyway, completely gone, and I think most people would agree with that.
And identifying dysplastic lesions within a colitic bowel, is a business.
Yeah, I mean, so there's this. So the time where it becomes really, really hairy is in fields of post-inflammatory polyps, or sometimes called pseudopolyps. That's kind of tiger territory to some degree, because it's quite difficult to survey there. It's not feasible or necessary to take all of the pseudopolyps away, of course. Trying to pick out the one that's dysplastic or potentially dysplastic is really difficult. And those patients are taxing for anyone, I think it's fair to say. In the absence of polyps or pseudopolyps, I think actually there was this entity of visible and invisible dysplasia. I often hear Boo Hay down at King's, who's obviously fantastic at this kind of thing, saying that there really is no such thing as invisible dysplasia, and if you have someone with the right eyes, the right techniques, the right scope, they will see it. We're not all quite that special, but I guess again it comes back to looking really carefully, taking time. If you see something you're not sure about, I think, to be honest, the right thing to do is, if it's easily resectable, you can resect it. If it's not resectable, you can take a biopsy of it. I think we do worry a little bit about biopsying lesions and making them difficult to resect later on. But I think if you're in two minds, I think it's really hard to tell someone, I'll just leave it alone. So I think the right thing to do is take a sample there.
And can I just ask? I mean, I know it's a whole other topic, but within most services, there are excellent colonoscopists who are committed to, the bowel screening program. There may be one or two who are spending much of the day, doing high-end endoscopic resection, ESDs and others. Who should be doing the IBD surveillance? Because in many units, they're quite big numbers of patients. But we work in ivory towers, but in usual practice, who should be doing these cases?
This is, in practical terms, it's quite tricky to answer. I mean, my own feeling about the activity assessments we talked about at the top of the show is that they should ideally be placed on someone who does IBD medicines, because they can make treatment choices at that time, and you kind of save a lot of time and heartache for the patients potentially. This is a bit harder because actually it often is not around IBD activity and treatment choices. It's around endoscopic skills and lesion recognition detection more appropriately or more accurately. And so. Yes, I think it should be someone who has those kind of lesion detection skills. And so I guess the question is, can we acquire those? Can the rest of us kind of upskill ourselves to make sure that we can detect a dysplastic lesion, or at least feel we can confidently? We can tell normal from abnormal, which is kind of what this is. And I think when you get into areas where there's potentially multifocal dysplasia, or there's a large flat polyp which is difficult to resect, then I think we're talking about someone who's got specific skills, beyond what most jobbing gastroenterologists maybe would have. And I think then we can pass over to those people who do bowel cancer screening, take away the big polyps, etc., do ESD maybe. But I think most of us should be able to recognize normal from abnormal and see a dysplastic area.
We're great discussion, and we're nearly coming to the end. Some great questions that have come in. One is, you find dysplasia, should that patient go for cross-sectional imaging? And almost an extension of that, in the olden days, if you found dysplastic areas in colitis, that patient was going off to the surgeons. Give us a slightly more nuanced view of the surgical question and a comment on imaging having found dysplasia.
Thanks for the question, Angad. And I'm sure you know a great deal about this with your background. I think it slightly depends on the grade of the dysplasia. I think if you find an area of low-grade dysplasia, probably even high-grade dysplasia, there isn't likely going to be anything on cross-sectional imaging. I think most of us would feel more comfortable if there is high-grade dysplasia to have some staging, just to make sure we're not missing more significant disease. And your other question was about what to do with those patients with dysplasia. And then that does depend on the grade of dysplasia, whether it was visible or invisible, and whether it's resectable. Usually what it comes down to is resect what's resectable and have an earlier follow-up rather than 3 years or a year, maybe 6 months to having a look, and make sure that follow-up is done with someone who is, as you kind of came back to, George, expert in dysplasia detection and removal, ideally.
Fantastic. Okay, listen, Mark, we're out of time. That was I think we covered a lot of areas. It's such a moving field, and we could talk all evening. Thanks ever so much for that. That was superb. I would just say to the people watching, there's any bits you've missed and you want to go back to, then this discussion is on the Gastro Learning site, and it's I'll certainly go back and go over those scoring systems and take some pictures of them and stick them on the wall at UCH if they're not there already. So Mark, thanks ever so much, and thanks everybody for joining, and have a great evening. All the best. George.